So, dear trainees, welcome and thank you for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So, you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Professor Dr. Hitesh Verma to start this session. Welcome, sir. Over to you.
Good evening, everyone. My topic is basically radiology on nose and paranasal
Dr. Hitesh, just a moment, sir. Can you just decrease the volume of your system because there is echo?
Shall I? So my topic is predominantly radiology of nose and paranasal. So I will combine it with anatomy of nose and paranasal sinus. So why this topic is important? Because nose and paranasal sinuses are basically compile of four different group of paranasal sinuses and nasal cavity. And there's a number of anatomical variation which we can see within the nose and paranasal sinuses. So that's why we are discussing this topic, and because of improvement in assessment technique by the view of endoscopes and computerized CT scan, we can access this sinus endoscopically and we can remove the disease. So this lecture predominantly focus on the lateral wall because the medial wall only septum is. So that I will discuss later on also. So predominantly lateral wall, nasal wall, we have three different elevation which is known as conchas: inferior concha, major concha, and superior concha. And space underneath to these is known as meatus. So deep to the inferior concha is inferior meatus, middle is middle meatus, and medial to superior concha is the sphenoethmoid recess, and lateral to it is the superior. So right from anterior to the posterior. So these are the initial cuts when we start nose and paranasal sinus radiology. So cuts start right from the anterior table of the frontal sinus. For this one, these are the coronal cuts. So cuts start right from anterior table of the frontal sinus till the posterior table of the sphenoid. So here in this radiology, in initial cut, we can see air film space above the orbit is known as frontal sinus, and here we can see interfrontal septa. In same radiology, we can see initial part of the sinus on both sides.
Dr. Hitesh,
Yes.
sir, your voice is breaking.
Hello.
Sir, your voice is breaking. Can you just
Now it's better.
Yeah, now it's better, sir.
Okay. So in initial scan, what we see frontal sinuses and septum and initial of inferior turbinate, or if it is we are going posteriorly, we can see initial of middle turbinate. So it's somewhere in almost slightly posterior to the initial part of the nasal cavity. Here we can see both side maxillary sinuses, and this one is a vomer bone lower part, and this one is a perpendicular plate of ethmoid bone. So here we can see deviation of the nasal sinuses, and this is the interfrontal septa. And normally frontal sinuses have a scalloping pattern, which lost generally in the case of mucosa. This is a corresponding endoscopic picture of nose and paranasal sinuses. This one is a middle turbinate. Here we can see initial of middle turbinate. Here is an uncinate process. And this one is the middle meatus, and this one is septum. And this one is along the floor of the nasal cavity. This one is an inferior turbinate, inferior meatus, and this one is nasal cavity, and this one is a middle turbinate. Initial most cell of nose and paranasal ethmoid primarily cells start from the ethmoid air cells. So first cell is the agar nasal cell. So this is the limit where first cell will appear, This is the agar-nasal cell. These are the single cell, and this is the anterior-most ethmoid cell. When we go posterior to from it, here in this picture, we can see in red one is a agar-nasal cell, and sorry, red one is a frontoethmoid cell. And if it is a single cell, there are four different variations: single cell, multiple cell, cell is extending, less than 15% of cell is extending within the frontal sinus and more than 50% of cell within the frontal sinus, or sometimes isolated frontal sinus cell. So these are the four different type of frontoethmoid cell. And this one is a corresponding picture, endoscopic picture. Here we can see agar-nasal cell. If uncinate process is removed or directly enter through this part. So this is again same example. Here what we can see. So this is a site where we generally, this is basically endoscopic picture. This is a maxillary line which, so this one is nasolacrimal sac is primarily present just behind this maxillary line. So for DCR surgery, we generally raise the flap uh, above the axilla of the middle termen anteriorly and extending inferiorly. Then we can expose a bone, and once this bone is removed, we directly reach till the nasolacrimal sac. And once the medial wall is punctured and communicated with the nasal cavity, then it is known as DCR, dacrocystal rhinostomy. So in the corresponding part, we can see the middle termen. This one is a septum. Again, these are the maxillary sinuses. This one is a anatomy proper where we can see agar-nasal, which I already told you. Above this is a frontal sinus. So how we can differentiate between the frontal sinus and the supraethmoid cell? It's basically if bony continuity, like in this picture, we can see if bony continuity is present in between the orbit or in between the frontal cell, then it is known as frontal sinus. Once this bony continuity is lost, then comes a frontal recess. So in this area, we can see frontal recess is started appearing, and this one is a frontal sinus. And rest I told you. And here, this one is a frontal sinus. This one is an outflow tract. So here, uncinate process we can see. So uncinate process attachment I will discuss later on. This one is a frontal recess. So frontal sinus, frontal recess. Here we can see agar-nasal cell, frontoethmoid cell. So frontal recess is a space behind to it, or posteriorly it is defined by the bulla ethmoidalis. Like here we can see. So if agar infection involving the agar-nasal frontoethmoid cell, it can compromise the drainage, or if it is involving the bulla ethmoidalis, it can compromise the drainage of the frontal sinus and can present in the form of frontal sinusitis or in the form of mucosal. So here we can see uncinate process. So uncinate process have three different attachments. One is it can attach to the laterally to the lamina papyracea, or medially to the middle terminate, or directly at the level of the skull base. If it is attaching over the lamina papyracea, then it creates a blind sac from the upper end of the uncinate process in the lamina. This is known as this is terminal sinus. When uncinate process attach with the lamina papyracea, in that case, frontal sinus drain into the middle meatus. Okay, and if it is attaching with the skull base and the middle terminal, in that case, frontal sinus drain into the ethmoid infundibulum, which is a space lateral to the uncinate process and medial to the medial wall of the maxillary sinus. Here we can see this is the ethmoid infundibulum, and one attachment is at the level of skull base. Here we can see direct attachment over the skull base. So different type of drainage. If it is attaching in directly to the lamina, then drain into the middle meatus, and if it is attaching with the skull base or middle terminal, then frontal sinus drain into the ethmoid infundibulum. So here, middle turbid we will discuss later on, but in this picture, what we can see, this is a lamellar part of the middle turbid, and this one is a lower bulbar part of the middle turbid. So here we can see here within the middle turbid, this is known as concha bullosa, If it is significantly enlarges the volume of the middle terminate, in that case, ethmoid infundibulum dimension will be compromised, and the drainage of the maxillary sinus can compromise, and then it can lead to maxillary sinusitis. So here is the middle terminate. Middle terminate have three different attachments. One is directly at the level of the skull base, where the lateral lamella, medial lamella meet with the lateral lamella. This one is in the vertical plane. But when we go posteriorly, it attaches in the frontal plane with the lamina papyracea and horizontally with the lamina papyracea. They're the two different attachments. So when it is attaching in the frontal plane, that is known as ground lamella. So we generally during the PES, we remove ground lamella to reach the posterior ethmoid cell, because anterior ethmoid cells are present anterior to the ground lamella and posterior ethmoid cells present posterior to the ground lamella. For the stability of the middle terminate, we should preserve vertical attachment and the horizontal attachment. This intermediate attachment we can remove to access the other sinus. It will not compromise the stability of the middle terminate. So these are the few anatomical variations. Like here we can see concha bullosa on right side, pneumatized middle terminate. This one is a collection of fluid within the middle terminate. Sometimes fungal muck can occur within the middle terminate, or this may be the starting point of the infection. And here the again this one is a paradoxical middle terminate. Normally middle terminate is curved towards basically concave side is towards the ethmoid infundibulum. But when this concave side is towards the septum, then it compromises the space lateral to the middle terminate, which it can lead to maxillary or ethmoid sinusitis. This is known as paradoxical. And here is the uncinate process. This is the endoscopic picture. This one is septum. This one is uncinate process. This one is a bulla ethmoidalis. So here we can see uncinate process. Anteriorly it attached with the lateral nasal wall, and posteriorly is a free edge. But when it goes superiorly, it attaches with the lamina papyracea to the skull base and to the middle terminal. And here is one of the anatomical variation where the middle term, uncinate process is pneumatized. And it can lead to some amount of infection in both of the sinuses. At the initial, this is at the level of ostium, and this is within the sinus. So this in this photograph, what we can see, this one is septum. Septum is deviated to the left side, and this one is a crista galli. This is the elevation which we can see at the level of the skull base. And if we return to this is the olfactory fossa. So where the olfactory nerve fibers from the nasal cavity enter into the cranial cavity. So this is the cribriform plate, medial lamella. And here middle terminate attaches with at the junction of medial lamella with the lateral lamella. So this is a olfactory fossa. So if depth is basically classified by the Kiros into three different kinds, which we will discuss later on. In type 1, it is up to 3 mm, depth is 3 mm. In type 2, it's 4 to 7 mm. And in type 3, 8 or more. So if depth is more, in that case, risk of injury during the FES to the lateral lamella is high. But when depth is less, in that case, fovea, this one is a fovea ethmoidalis, this will be low if Heroes is less. In that case, injury to the fovea ethmoidalis is high. So here we can see middle terminate attaches at this junction. These are the ethmoid cells. And this one is a fovea ethmoidalis, which is continuous laterally with the merged laterally with the frontal bone. So this one is the frontal recess. We can see frontal sinus draining within the nasal cavity. This one is a bulla ethmoidalis. And this one is a maxillary sinus ostium. This one is maxillary. So behind the uncinate process, maxillary sinus ostium is seen, and this area is known as ethmoid infundibulum. Here, this is a demarcated area. So this is the endoscopic picture. This one is uncinate process. Once uncinate process is removed, here is the maxillary sinus, and this one is a bulla ethmoidalis. So this I already told you. Kiros three different type 1, type 2, and type 3. So in this photograph, we can see it's a type 3. It's a significant depth, medial lamella, lateral lamella, and from there the fovea ethmoidalis. Till this is a form. These bones are formed by the ethmoid bone, and then comes a frontal bone, which this is a posterior lamella, posterior wall of the frontal sinus, and this one is the anterior wall. And this communicate with the nasal cavity. This one is a frontal recess. This is the middle terminal. This one is the inferior terminal. So here in this photograph, what we can see, this red dot is where the anterethmoid artery enters within the nasal cavity, in the cranial cavity. So when anterethmoid artery, this is a branch of the ophthalmic artery. It runs in between the medial rectus and superior oblique muscle. So from where it enters into the nasal cavity, and from nasal cavity, it runs predominantly within the skull base. But in up to 10% of the cases, it can run deep into the nasal cavity. In such cases, when dealing during the surgery at the level of the skull base, risk of injury is high. So pre-surgical assessment of the radiology is very important. What is the type of heroes and where the anterethmoid artery runs. So from here, the anterethmoid artery gives branches. Few goes intracranial, few come within the nasal cavity. And the cribriform plate is the thinnest where the anterethmoid artery enters into the nasal cavity. So this is a predominant site where CSF leak occur, spontaneous CSF leak occur. This is a basically sagittal cut. This one is a frontal sinus. Agarnizi cell. Here we can see pneumatized agarnizi cell. This compromise the drainage of the frontal sinus. And this one is a bulla ethmoidalis. Here we can see this one is a ground lamella. And from ground lamella, this one is, these are the postethmoid cells, and this one is a sphenoid sinus. And here pituitary can appear. So this is the drainage. For sagittal cuts, this is the what we can see in sagittal cut. One is the drainage of the frontal sinus, and one is the relationship of the pituitary fossa with the sphenoid sinus. This we will discuss later on. Next comes the osteometal complex. So any disease in early stage predominantly involves the osteometal complex, especially sinusitis. So what all comes in osteometal complex? Middle terminate, uncinate process, ethmoid infundibulum, bulla ethmoidalis. So these five structures and maxillary sinus osteum, these five structures come under osteometal complex. This is a corresponding picture, endoscopic picture, middle terminate, uncinate process. This one is uncinate process. This one is a bulla ethmoidalis. And a space later to the uncinate process. This one is a hiatus embryonalis, space in between uncinate process and bulla ethmoidalis, and a space later to the uncinate process. This one is ethmoid infundibulum, which is later to it. One anatomical variation of enterethmoid cell is a Heller cell. Here we can see Heller cell. This is a cell which present at the level of the maxillary sinus osteum. So any infection involved, these cells can compromise the drainage of the maxillary sinus. In that case, some maxillary sinusitis can happen. Like here, we can see some amount of infection, and this can lead to initial stage of sinusitis. So next come after the this one is a bulla ethmoidalis. When bulla is non-pneumatized, then it is known as torus ethmoidalis, which is a relatively rare case. Once we remove the bulla ethmoidalis, then we can see ground lamella in the middle terminal. This one is a ground lamella after the removal of the bulla ethmoidalis. Once ground lamella is punctured, then we can see posterethmoid cell. How we can differentiate between enterethmoid and posterethmoid cell? One, by assessing the position of the ground lamella on the radiology, and skull base, which is initially sloping, then it is slowly converted to horizontal one. And posterethmoid cell come in relationship of the orbital apex. So that is a differentiating point. Here in this arrow, we can see one attachment right from the skull base entering into the nasal. This is the superior terminal. So space later to it is a superior meatus, and space medial to it is the sphenoethmoid recess. From this space, sphenoid sinus drain into the nasal cavity, and from here, posterethmoid cells also drain into the nasal cavity. Next comes the Onodi cell and optic nerve relationship. So Onodi cell is a posterior most posterethmoid cell. This is basically pneumatization of the ethmoid air cell extending towards the sphenoid. So in that case, optic nerve comes in relationship with the on OD cells. So pre-surgical assessment of the radiology is very important, because if surgery is done without prior understanding, then optic nerve injury can happen. So this is a radiology. There are 4 different kinds of cells. This one is a type 1 optic nerve. Here is no on-OD cell, only there is no indentation created within the sphenoid sinus by the optic nerve. In second picture, we can see some amount of indentation. In third picture, it is running within the sphenoid sinus. And in fourth picture, this one is a on-OD cell. So normally in sphenoid, there's a vertical septum. So that is intersphenoid septum, which in between 2 sides. But when we can see horizontal septa within the sphenoid channel, then above this horizontal septa is a cell and below is the sphenoid. So here we can see optic nerve running within the NAD cell, close to the vicinity of the NAD cell. So this is a better picture. This one is a point. This one is the rostrum of sphenoid channel, which is the extension of the sphenoid bone into the nasal septum. Here is the intersphenoid. Intersphenoid septum can be in the midline or can be off midline. Sometimes it is extended laterally and attached at the level of the optic nerve or the carotid artery. This is the region of optic canal. Here we can see, and this is the region of carotid artery. So when someone is doing septoplasty, or if we are removing the septum inadvertently, then we can injure the carotid artery or optic nerve. So blindness and the risk
Dr.
of
Hitesh,
yes.
sorry to interrupt, sir. Your voice is breaking a lot, sir.
हेलो अभी है क्लियर
नहीं सर, क्लियर नहीं है इतना.
अभी राइट नाउ
Okay, just continue. Let's see.
एंड राइट नाउ
No, sir, it's still breaking, sir.
नाउ हेलो
Yes, sir.
नाउ इट इज क्लियर
It's better.
okay so now what we can see this is a posterior most cut so right as we discussed initially from the anterior table of the frontal sinus we are going posteriorly till the probably last end of the sphenoid sinus so here's the optic nerve this one is a carotid canal so these carotid canal and optic nerve comes in later relationship of the sphenoid sinus and here we can see septa and which is attaching at the level of carotid artery. This one is a foramen rotundum. From foramen rotundum, median canal comes into the this pterygomaxillary fossa. So this is a basically landmark for carotid canal. If we are following from the pterygomaxillary fossa posteriorly along this median canal, so we can reach till the carotid artery. So this is a limit for surgery postal limit because we can use this landmark if we don't have navigation system. In that case, that can be used. And this one is a nasal septum, choana, and soft color. So these are the axial cuts. Right from this one is anterior and this one is posterior. This one is a nasal septum. Okay. And this one is a nasal bone. Frontal, basically, this is a frontal process of the maxilla. And from here, we can see nasolacrimal line. And this one is a middle turbinate. And this one here, we can see this is a ground lamella. So cells anterior to the ground lamella is known as anthrhythmoid cell, and cell posterior to the ground lamella is posterethmoid cell. And from medial to, if we go medial to the middle turbinate, we can reach directly within the sphenoid sinus. So if disease is limited, in that case, we can go directly medial to the middle turbinate. Like in this photograph, we can see this one is a septum. This one is a left side of the nasal cavity. This one is septum, and instrument is used to displace the superior turbinate. And this one is a ostium. Like here, we can see middle turbinate and superior turbinate displaced laterally. Then we can reach directly within the sphenoid channels. So this is the sphenoethmoid recess, and here we can see lateral relationship with the optic nerve, carotid canal. Carotid canal can be seen, and this one is an interior intersphenoid channel. Next comes the sphenoid sinus. So, as we discussed, uses of sagittal cut is only to assess the frontal outflow tract and the sphenoid sinus pneumatization pattern. So, this one is a pituitary fossa. So, if a sphenoid sinus pneumatization is absent or minimal, then it is known as conchal type of sphenoid. If it is extending till the anterior part of the pituitary fossa, then it is known as presellar. And if it is extending till the sella or beyond the sella, then it is known as sellar type of pneumatization. The natural dehiscence, that means party wall in between the optic nerve or carotid canal can be dehiscent. This can be seen in 8 to 22% of cases. When pneumatization pattern is high, like all the subsides are pneumatized within the sphenoid channel, in such cases, natural dehiscence can be seen. Like here we can see, these are the hyperpneumatized sphenoid sinus uh, extending in between the optic canal and carotid artery. This is known as optical carotid recess. So this is a airspace created in between this. This one is along the pterygoid belt. So retropterygoid pneumatization. Here we can see significant amount of pneumatization, opticocarotid recess, and extending along the pterygoid plate postlaterally. So if anyone is doing extended endoscopic surgery, so in that case it would be required because sphenoid sinus is a corridor for posterior cranial fossa, middle cranial fossa. So if surgeon is going from the roof to the brain, then it is middle cranial fossa. If it is going through the posterior wall into the brain, then it is you can access the posterior cranial fossa. The sphenoid septum, I already told you that midline sphenoid septum is rare and accessory sphenoid septum inserted over the carotid canal is seen in 16 to 25%. Like here in this case, we can see it is extending to the carotid canal. So this was a case where surgery was done septoplasty and surgeon inadvertently excess very much posterior injured the septa, and this leads to caroticocavernous fistula. Patient presented to us with significant amount of bleeding. Here we can see damaged septa. So significant amount of bleeding was occurred. So patient was managed with uh, uh, by intervention radiology by coiling and obliteration of the defect site. So how we can select a approach for sphenoid? Like here in this case, there's a limited infection is present within the sphenoid channels. So in that case, we can access directly into the sphenoid channels medial to the middle tunnel. But in this radiology, we can say significant expansion of the sphenoid channel. So medial access will not be helpful. In that case, we can access through the uncinate process, enterethmoid, we can remove post-ethmoid, that can be removed. And then sphenoid sinus can be accessed. This is known as lateral access. So in that case, if a sphenoid disease is significant, and then lateral access is required, and if it is diagnostic or limited disease, then medial access can be sufficient. Then this is an enterethmoid cell, which I already told you. So this is a Kennedy's nipple, where the enterethmoid artery exit from the orbit. So this is a pointed area, which we can see within the radiology. In this film, we can see it's running within the cranial cavity, but in this cut, we can see it is running within the nasal cavity. So here the kilos is small, either 1 or 2. Here the kilos is high, 3. Now, other condition where enterethmoid artery can run within the nasal cavity, if we can identify supraorbital cells. So this one is a supraorbital cell. These are the cells which present above the orbit, which is the extension of pneumatization of sphenoid sinus over the orbit. Then there's a wide frontal ostium anterior to posterior. Here we can see wide anterior to posterior. If it is more than 1 centimeter, then there is a chances enterethmoid artery runs within the nasal cavity. So this is the enterethmoid artery. And if it is a cribriform plate, along with depth, length is more. If longer is the length of the cribriform plate, in that case, it can also run within the nasal cavity. Then axial cut from above downward. So axial cut start from the upper end of the frontal to the hard palate and soft palate junction. So in this cut, what we can see the initial of frontal sinus, then both frontal sinus merges, and then it is extending slowly progressive posteriorly, and medially will becomes a ethmoid sinus, and this posterior is a frontal sinus. Finally, they both it enters into the recess, and here we can see entirely within the nasal cavity. This one is a this crista galli, and on either side we can see olfactory fossa, and this one is an attachment, probably upper attachment of the middle turbinate, and both sides we can see ethmoid air cells. And here we can see frontal sinus start appearing, sphenoid sinus is start appearing, and this one is optic nerve. So what we can see in these axial cut, one is position of lamina papyracea. Like here we can see lamina papyracea is completely intact, and we can see this one is the pterygomaxillary sphenopalatine foramen, and from sphenopalatine foramen pterygomaxillary fossa and extension into the infratemporal fossa. For example, JNA nasopharyngeal angiofibroma can usually start from sphenopalatine foramen and extend later into the pterygomaxillary fossa and extend into the infratemporal fossa, and it can immediately extend into the nasal cavity and paranasal sinuses. So other structure which we can see in this cut is the relationship of the nasolacrimal duct. So if nasolacrimal duct, like in this case, here is a nasolacrimal duct. So if nasolacrimal duct runs within the medial wall, in that case, if someone is doing posterior to anterior uncinectomy and widening of the sphenoid sinus from, maxillary sinus from posterior to anterior direction, in that case, injury to the nasolacrimal duct can happen. And if it is running right, if it is running at the junction of anterior wall and the medial wall, in that case, risk of injury is less. So pre-surgical assessment of the course of the nasolacrimal duct can prevent the injury to the nasolacrimal. So in this case, we can see position of septum. These are the maxillary sinuses, and this one is the nasopharynx, pterygoid plates, medial pterygoid plate, lateral pterygoid plate, and this one is an infratemporal fossa. So normally infratemporal fossa contain fat. So like in cases of invasive fungal sinusitis, so loss of this retroantral fat plane is the initial sign of infection in the cases of invasive fungal sinusitis. So this is another picture. In this case, we can see nasolacrimal duct running right at the junction of anterior wall and medial wall. In that case, if it is widening, it's done from posterior to anterior direction. The risk of injury to the nasolacrimal duct is less, but in this case, it's high. Then this is a lamina papyracea, which I already told you. If the imaginary line is passed along the lateral wall of the nasal cavity, if lamina papyracea is medial to this, then surgical corridor in the ethmoid cells is less. In that case, risk of injury to the orbit is high. Whereas comparison to this, here we can see lamina papyracea is lateral to this line. In that case, risk of injury to orbit is relatively less, and surgical corridor is much higher. Then comes a simple nasal cavity assessment. So this one is a first pass. So what we can see, this one is septum, this one is inferior turbinate. So here we can see deviation, S-shaped deviation. This one is a spur. This one is inferior. This is completely septum is in the midline, and here we can see nasopharynx, fossa of Rosenmuller. So that can be seen similarly on radiology. So these are the few pathologies: septal perforation. These are the cases of nasal polyposis. This is a case of angiofibroma, and this one is adenoid. So in second pass here, we can see discoloration of nasal septum. So this is a case of mucormycosis. This picture I already showed you, sphenoid sinus ostium, and this is a mass within the superior mucus. And this is the third pass. This picture I showed you multiple times. So traditionally, if we go from anterior to posterior direction, that is known as Maziklinger technique. To identify, basically what we can identify is attachment of the uncinate process, and if surgery is done from anterior to posterior direction, then if lamina papyracea is medial or uncinate process is diverted later, in that case, injury to the orbit can happen. And if it is done from posterior to anterior, that I already told you, there's a risk of injury to the nasal eclampsia duct. So anterior ethmoid. This is basically complete the radiology topic. Limited amount of discussion we can done on complication related to it. So how complication can be avoided? Thorough knowledge of anatomy, proper assessment of preoperative imaging, presence of tools like endoscopes, debrider. If disease is extending significantly, then image guidance. So normally, for investigation of choice for nose and paranasal sinus is the CT scan, NCCT PNS orbit. If patient present with bleeding or if there is vascular mass, then contrast imaging is indicated, or usually cut required 3 to 5 mm. But when disease is significantly extending along the skull base, in such cases, 1 mm cut can be asked for image guidance purpose or better assessment of the anatomy. Another one is a hypotensive anesthesia that can prevent complication. So complication can happen with revision surgery when there is extensive disease, when party wall within the sinus with the orbit or cranial cavity is dissect. In that case, injury can happen. When the sinuses are hypoplastic, then risk of injury is here. And when there's a anatomical variation, like in this radiology, what we can see, skull base on left side is much lower than on right side. So if this kind of anatomical variation is there, then if we are dealing both sides in the same way, then we can injure left side more, skull base risk of injury is more. So landmark which we can take during the revision surgery like middle tablet, posterior coina, sphenoid, skull base, septum, and maxillary sinus fluid. So this is a list of complications. CSF rhinorrhea. The most common complications is synechia, hematoma formation, nasal bleeding. These are the nasal complications which are relatively common. Then comes the orbital complication, which include orbital emphysema, fat prolapse, diplopia, injury to nasal eclampsia duct. There may be loss of smell, orbital hematoma, or intracranial complication like CSF rhinorrhea, encephalocele, meningitis, cavernous sinus thrombosis, and intracranial abscess can be found. So pre-operative detailed assessment of anatomy is very important because if radiology is not assessed properly, then the risk of injury is high to anatomy, which I told you. Thank you.
Dr. Hitesh?
Yes.
Excellent. So, dear trainees, I'm sorry there was a audio issue, but you may type your questions, comments in the chat box, and if you want to any of the point to repeat, please type in chat box so Dr. Hitesh Verma will be able to explain it again. Thank you. Dr. Nilima, welcome.
Mr. Navneet. Good evening, Hitesh.
Good evening.
I was having some technical problem, was unable to unmute myself. So, uh, so your talk was absolutely spot on. Thank you so much. I was thinking the AIMS has a workshop going on, so maybe you will not be able to do it. So, but thank you. Thank you for doing it. So, do we have any questions in the chat box?
Yes, Dr. Hitesh, just move your cursor to the top and open the chat box.
Yeah, I opened it. So there's a one question. Kindly tell us about ethmoid artery, carotid artery, and sphenoid sinus. Few sites repeat.
Actually, initially, then it was okay. I think towards the end it was okay.
So yeah,
But
this
maybe
is
the ethmoid artery and that part you can repeat, Hitesh.
yeah, ma'am.
Just What slides?
Now this, can you see my slide? Yes, sir.
Yes, we can.
Yes. So this is a sphenoid sinus.
Yes.
So in a sphenoid sinus, optic nerve come in relationship with the optic nerve and carotid canal come in lateral relationship with the sphenoid sinus, and pituitary gland come in posterior relationship with the sphenoid sinus. So there's a three different kind of pneumatization which we can see in sphenoid sinus. One is concal, where is no pneumatization or minimal pneumatization. Next comes a pre-cellar, when pneumatization extending till the cellar. When it is extending below the cellar and behind the cellar, then it is known as cellar kind of pneumatization. When pneumatization is uh, either cellar or post-cell, as the pneumatization increase in capacity, in that case, surrounding wall will be thin. So in that case, if we are dealing with post-cellar or cellar kind of pneumatization, in that case, we can identify natural dehiscence along the optic canal or along the carotid artery. In that case, if disease is significantly involving these sinuses, then the risk of injury to the optic nerve and carotid canal is high. So whoever is doing surgery should assess uh, radiology beforehand so that injury can be prevented. And what surgeon can do, first deal in the central part of the sinus and then slowly progress to the lateral part, so that anatomy can be clear and avoiding any pulling and uh, pulling tissue from the lateral part, because it can injure these structures. And another structure which runs along the lateral wall is a Vedian canal, which is a basically, if we are doing extended surgery, in that case, this is used as a landmark to identify the carotid artery. And this Vedian canal is also widened in the case of juvenile nasopharyngeal angiofibroma, because sometimes Vedian canal supplies the angiofibroma, or sometimes this is an area where we can left the disease during surgery. So widening of the this Vedian canal is required if it is taking if it is providing blood supply to the angiofibroma, because complete disease removal is possible only by widening of this sinus. Other one is this enterethmoid artery. So here is an enterethmoid artery. So enterethmoid artery is a branch of ophthalmic artery. So it runs from the orbit into the nasal cavity in between medial rectus and superior oblique muscle. So here we can see superior oblique and medial rectus. So it comes from the nasal cavity, and then it around 90% of the cases it runs within the cranial cavity. So there is a no risk of injury. But in 10% of the cases, it can run within the nasal cavity. So what are the conditions where we can identify it within the nasal cavity? When there's a significant pneumatization within the nose and paranasal sinuses, like if supraorbital ethmoid cells is present, like here we can see supraorbital cell. So here enterethmoid artery runs within the nasal cavity. When there is a wide ostium, like in this is an endoscopic picture, when there is a anterior and posterior wall of the maxillary sinus are very much apart, 1 centimeter and beyond, in that case it can run within the nasal cavity. Other one is a Kiros type 3, like in this case we can see Kiros type 3, where the depth is more than 8 mm is considered as Kiros type 3. In that case it can run within the nasal cavity. And other one is a cribriform plate length, like here we are discussing only depth. If it is length is more anterior to posterior, in that case it can run within the nasal cavity. So I told Kiros also, and ethmoid artery position also. Any other question? So sphenopalatine foramen. So here we can see the axial cut. So sphenopalatine foramen is visible within the axial cut. It is seen in the posterior part of the nasal cavity. So normal in endoscopic anatomy, it is a posterior most part in the middle meatus, where we can identify sphenopalatine foramen. So sphenopalatine foramen is here. It is extending laterally into the pterygomaxillary fissure, then fossa, then fissure, then infratemporal fossa. So in angiofibroma, it start predominantly from this sphenopalatine foramen and extend laterally. So if it is extending laterally, in that case, it can push, like here we can see it can push the posterior of the maxillary sinus anteriorly, then it is known as Hohmann-Miller sign. And if it is extending laterally into the infratemporal fossa, then it can extend into the chi. Then patient can have facial deformity. Any other question? I think, ma'am, there is no question.
Sir, you have taken Dr. Monica's questions?
Yeah, this one is Dr. Monica's question, which I explained just now.
Okay, there's one more question from Dr. Ish.
So here we can see one person is asked pterygoids and pterygopalatine fossa. So in this radiology, here we can see sphenopalatine foramen, then it is extending into the pterygomaxillary fossa. So it is normally it is not much widened, but when there's a disease is there, in that case it can be widened. And is behind to this is the pterygoid plates. This one is a medial pterygoid plate and this one is a lateral pterygoid plate. Muscle here we can see it is lateral pterygoid muscle, which is extending from the lateral pterygoid plate to the this one is condyle of the mandible, and this one is a medial pterygoid plate, a medial pterygoid muscle, which is extending from the medial surface of the lateral pterygoid plate to the inner aspect of the mandible. Here we can see this one is a medial pterygoid plate, medial pterygoid muscle. So this one is a Kunz classification. Single cell present above the agarnicite cell, it's known as type 1 cell. If there is a multiple cell, then it is known type 2 cell. If cell is extending into the frontal sinus, but less than 50% of the frontal sinus, the height is less than 50%, then it is known as type 3 cell. And if it is extending above the 50%, then it is known as type 4 cell. And optic nerve. So this is a ONOD cell and optic nerve relationship. Normally optic nerve come in supralateral aspect of the sphenoid sinus. So this one is a type 1, where no indentation is created within the sphenoid sinus. In type 2, there is some amount of indentation we can see. In type 3, these cells are present completely, optic nerve is present completely within the sphenoid sinus. But here is no ONOD cell. When it comes in relationship with the ONOD cell, it is automatically comes as type 4. So normally sphenoid have vertical septa. Like here we can see vertical septa. But when there is a horizontal septa, then it is above this horizontal septa is ONOD cell and below is a sphenoid sinus. So here is a ONOD cell and optic nerve is come in lateral relationship with the ONOD cell. So posterior cell. So in similarly, in this picture, we can see this one is a posterior cell. It is in predominantly, almost 99% it runs within the skull base. So it's less likely to be injured in routine endoscopic sinus surgery. When anyone is doing extended surgery, like going through the plenum. This one is a sphenoid channel. This one is a plenum part. And if anyone is doing removing this plenum part, then there can be injury, and it can be easily manageable. So if someone is doing endoscopic surgery and if it is coming within the nasal cavity, it's better to do first expose a skull base so the entire artery can be visible. If it is coming in the if it is hindering the surgical field, then cauterization can be done in middle part. So if there is some amount of retraction occur, still you can handle in other part. So this one is a 3D picture of middle terminate. So middle terminate from anterior most end, like in this endoscopic picture, we can see this is a middle terminate. It is attaching superiorly at the level of the cribriform plate. So here in this photograph, we can see cribriform plate. So this one is a medial lamella from where the olfactory nerve fiber goes from the nasal cavity into the cranium. And this is a lateral lamella. So this one is a vertical attachment. These are the two horizontal attachment. One is in the frontal plane to the lamina papyracea. Second one is a horizontal plane to the lamina papyracea. So this frontal plane can be, this is known as ground lamella, and this can be removed during surgery to expose the posterior ethmoid cells. Delano classification I already told twice. This is the optic nerve classification. So here we can see attachments of the uncinate process. So normally uncinate process here, this is endoscopic picture. It attaches anteriorly with the lateral nasal wall. So lateral nasal wall is formed by the frontal process of maxilla and posteriorly by the lamina papyracea. So it is attached at that level. So deep to this, we can identify the sac. Here, if someone is doing surgery, the nasolacrimal sac can be identified in that place. Then posterior is a free, posterior border is a free, and behind this is a hiatus seminaris. And lateral to it is a, this one is a ethmoid infundibulum. And superiorly it attaches either with the lamina papyracea, with the skull base, or with the middle termen. If it is attaches with the lamina papyracea, in that case, frontal sinus drains directly into the middle meatus. One method attaching to the skull base or to the middle termen, in that case, frontal sinus drains into the ethmoid infundibulum. From the ethmoid infundibulum, via the hiatus seminalis, it drains into the middle meatus. And paradoxical, this one is a basically pneumatization of the uncinate process. So this one is only paradoxical. Sometimes it can attaches, like if surgery is done in that case, it can be paradoxical. Otherwise, for paradoxical, it's basically for term is used for middle terminate. This one is a paradoxical middle terminate. Normally, this one is a healthy side. Here we can see concavity towards the middle meatus, but here we can see convexity towards the middle meatus. So here we can see this is a good space, and here the space is less. So if any infection occur in left side of the nasal cavity, then patient can land up early in the maxillary sinusitis. So I answered last question also.
Yeah, yeah. I think there are no more questions.
So, if there are no more questions, thank you very much, Professor Dr. Hitesh Verma, for the presentation, and thank you very much, Professor Dr. Nilima Gupta, for joining. And thank you, trainees, for joining the session.
Thank you, Hitesh.
Thank you, ma'am.
Thank you for taking out time. Yeah. Thank